Bueno, perfecto. Muchísimas gracias a todos ustedes por acompañarnos hoy a mediodía. Este es un almuerzo de trabajo, cortesía de Twins and Martin. Jorge Hoyos, muchísimas gracias por acompañarnos y estar pendientes de nosotros y apoyarnos académicamente. Twins and Martin es una compañía con más de 30 años de historia y más de 30 filiales. Ya ustedes vieron en el video previo todo lo que nos ofrece y todo lo que hemos utilizado y estamos actualmente manejando nuestras AngioSuites. En la tarde de hoy tenemos un conferencista que ya será presentado con toda su hoja de vida por parte del doctor Varela, es el doctor Stéphan Haulon, y quiero iniciar dando presentación de quien va a ser nuestro conferencista, nuestro presentador, el doctor Juan Agustín Varela. Es médico de una prestigiosa universidad de acá de Bogotá, la Universidad del Bosque, cirujano general de la Universidad Javeriana, cirujano vascular del Arizona Heart Institute, profesor de cirugía vascular de la Universidad Javeriana y es instructor de cirugía vascular en el posgrado de la Universidad Militar y la Fundación Sanitas de Unisanitas. Es instructor latinoamericano de dispositivos avanzados de aorta y es el jefe de cirugía vascular a cargo actualmente de la organización Sanitas. Doctor Varela, muchísimas gracias y antes de iniciar quiero agradecerle al profesor Haulon por acompañarnos. Merci beaucoup, professeur Haulon, pour ton présence ici avec nous. C'est un plaisir. Profesor Varela, la pantalla es suya.
Buenos días, muchas gracias. Es para mí un honor presentar a Stéphan Haulon, que es una persona que no necesita mucha presentación, pero Stéphan es un gran amigo y Stéphan es médico de París y hizo su formación en cirugía vascular en Lille. Posteriormente estuvo en la Cleveland Clinic, donde hizo su fellow de research con el doctor Roy Greenberg, lo cual fue una magnífica experiencia. Después de esto volvió Stéphan a Lille y allí estuvo hasta el 2017. En sus últimos años fue el jefe del servicio de cirugía de Lille. Desde el 2017, Stéphan se trasladó nuevamente a París y ahora actualmente es el jefe del centro aórtico de Marie-Lanlong en el sur de París. Los principales intereses de Stéphan en la cirugía vascular, pues básicamente lo conocemos, son los dispositivos avanzados, los fenestrados, los ramificados. Ha hecho una gran evolución en el arco aórtico. También es un apasionado de la fusión de imágenes. Y también tiene un interés muy particular en los accidentes, eventos cerebrovasculares durante los implantes de dispositivos avanzados. Stéphan, je fais ta présentation. C'est un grand plaisir et un très grand honneur de t'écouter aujourd'hui. Allez-y. Merci beaucoup.
Thank you very much, Juan and Jorge. It is an honor and a privilege to be here with you today. Difficult times for everyone in Colombia now, and it's good that we can still interact and share our experience. And I'm going to focus my talk on the next half an hour on my experience with the bridging stents for fenestrated endograft and for branched endograft. This is my center. One was quoting in the south of Paris, and I hope that I will be able to welcome all of you very soon, and I hope that I will be able to visit you very soon also. This are my disclosures. So I have a research support and I'm a consultant with Cook Medical, GE Healthcare, and Bentley. Now, this is just to promote the book from my good friend Gustavo, and also to tell you that in my slides you will find a couple of anatomy figures that are anatomy sketches that are from that book that I really recommend for any vascular surgeon that has an interest in aortic endovascular procedures. So let's first focus on fenestrated endograft. And you know that the main goal of or the main challenge of fenestrated endograft is to go through the fenestration let me take the pointer here, and there you are. I don't know if you can see my pointer. So what you want to do is go through the fenestration with a floppy wire, then advance a catheter that you can see here to exchange the floppy wire for a stiffer wire like a Rosen wire, and then advance a sheath inside your target vessel, which is a requirement before advancing your bridging stent, your balloon expandable bridging stent, which in my practice is the B-graft peripheral. Now, most of the time it is quite straightforward, but in some cases it can be quite challenging, especially when you have downward renal arteries, such as this right renal artery here. Well, in those cases, one of the tips and tricks that I would like to share with you today is that when you really push your catheter over the wire into your target vessel, you can use the top of the fabric, because at this stage of the procedure, the graft is not open. So you can advance your wire and your catheter at the top and then track towards a downward looking target vessel. Here, I think this is the right renal artery here, and here a left renal artery. You can see various steps. Once your wire has looped at the top, advance your sheath to get more support, and then you have enough support to advance your catheter. And this is a short video showing you exactly what I just said. You see the sheath has been advanced. Now I'm positioning my wire far into the target vessel, and now I have enough support to advance my catheter. And once I have exchanged my floppy wire for a Rosen wire, then sometime you need to inflate a balloon at the origin of the target vessel to be able to advance the sheath. And you can see here a balloon is inflated, and when you deflate the balloon, then you can advance the sheath. And this is very important because there's a mismatch between the origin of the target vessel and the fenestration. So the balloon will reline everything. And then this is the selective angio after the B-graft has been implanted. But I'll show you in more details the various steps for the B-graft. Now, using the top of the fabric is a very interesting tip, but sometimes if you do thoracoabdominal repair, the top of the fabric is very far. So you don't have support from the top. It's not possible, it's too far. So in those cases, one other tip is to inflate a cutter balloon just above the fenestration. You can see here the cutter balloon is inflated. So now I can do the same. I can use support from above to track my catheter and then my sheath inside the target vessel. Also quite a useful tip. Now this is to show you that my practice has moved from 2 renal fenestration devices 10 years ago to almost 4 vessel fenestrated endograft now, because most of those juxta or pararenal aneurysm, if you look at the anatomy very carefully on the workstation, they have a posterior bulge at the level of the visceral aorta, sorry. And if you do not get a seal way above, then there's a risk that 2, 3, 5 years after the procedure, you have no more seal at the proximal end. And then relining a 2-vessel fenestration with a 4-vessel fenestration inside can be quite challenging. So that's why routinely now the 4-vessel fenestration device is our favorite design. Now, one of the issues if you do that is that on the other side, on the contra side, you will need to access 3 or 4 target vessel. And it is quite difficult to use large sheath, I mean larger than 20, because if you move to 20, 24, or 26, then there's a risk of rupture of your iliac, and this can end up in a catastrophe. So I'm moved away from putting a lot of sheaths on the other side, which was my initial my initial technique, I used to put 2 sheaths in the renal and then 2 balloons into the vessel prior to deploying the endograft. So I would secure the renal with 6 French sheaths, and I would just put balloons inside the vessel that I would inflate prior to release the endograft. Then once I had positioned my renal stent, I would then get the sheaths out and replace the balloon by sheaths, and then implant my B graft into the 2 visceral. So this is something you can do. It requires an additional step, but it is a good technique to manage small access when you cannot use very large sheaths. Now, another technique, which is my favorite technique, is to use a preloaded delivery system for your fenestrated endograft. So this is what a preloaded system is. At the level of the delivery handle, you have wires that are going inside the delivery system, and those wires, over those wires, you can push a 6 French 90 sheath, and 6 French is the largest sheath you can push in those preloaded system. And the sheath will track directly over the wire, directly to the fenestration. So it gives you a very stable platform, although you have a very narrow working space because the sheath is against the fenestration. Then keeping your preloaded wire in position, you advance a parallel catheter and wire to access your target vessel. And this is here the various steps of the procedure. You see the sheath has been advanced over the preloaded wire. You advance a catheter. I use most of the time a Vinci free catheter. You see I push my wire inside, then I push the catheter over the wire. And before you can advance the sheath, you need to take away the preloaded wire, because otherwise your sheath is stuck with one wire going up and one into the renal artery. And this short video shows you the sheath here, my small catheter here, and the wire going into the left renal artery. And as you can see, I perform all my cases under fusion guidance, which really makes those procedures much easier. Now, doing more and more of those preloaded procedures was one main reason for switching to the B graft, because the B graft is a 6 French compatible up to 8 millimeter diameter. And with the other companies, it was very difficult to always have the correct bridging stent when using 6 French sheaths. So this is funny because I moved to the B graft to be 6 French compatible. And now I actually also use the 6 French sheaths whenever possible for the SMA and for the celiac trunk, because it's much easier to track a 6 French sheath into a downward going celiac trunk rather than a 7 French sheath. So this was again my first reason to move to Bentley, but I moved to using routinely the B graft peripheral only when the 2nd generation B graft peripheral was available. For those of you who are not aware of that, there was a 1st generation which I think, well, I know was not designed to be a fenestrated or a bridging stent. It was designed more for peripheral or coronary procedures. So the new generation of B graft peripheral had modified stent connectors. They were much larger. They increased by 20%. And most importantly, was that the wall thickness was doubled. The initial B graft had 100 micron wall thickness, while the B graft peripheral that I'm using and I've been using for many years, that is currently on the market, has a 200 micron PTFE cover material, which completely changes the strength of this B graft peripheral. And you can see how precise it is and how you can flare your big graft peripheral to get a good seal at the level of the fenestration. In my practice, the renal fenestrations are 6 millimeter diameter. So I usually flare the renal stent with the 9 millimeter balloon. And my visceral fenestration are 8 millimeter large. So I usually flare the big graft peripheral with a 10 millimeter balloon. Now this is just a cone beam CT performed at the end of the procedure, and the post-op CT showing a case with 4 big graft peripheral as bridging stent. I always perform a cone beam CT at the end of the procedure because if there's any issue, I can fix it right away. And so it really reduces the number of secondary procedures that are required in those complex procedures. Now, one other benefit of the big graft peripheral is that when it was launched, it was the only covered balloon expandable stent that was available in large diameters but short length. And this is really useful, especially for the celiac trunk, which has, in many patients, a very early bifurcation, and also in order not to cover early branches of the SMA and to adapt better to the anatomy. Because if your bridge stent is too long, then you will have a kink between your bridging stent and your target vessel, especially the SMA. So having a 27 millimeter long platform in 8, 9, and 10 millimeter was really useful for our fenestrated cases. And you can see here 6 French sheath advance in the celiac trunk. You can see I think it's 827 big graft that is advanced. You can see the stent protruding in the aortic lumen, usually between 3 and 4 millimeter of stent protruding. And I'm going to show you the video again because I want to show you that once the balloon has been inflated, I push on the shaft so that the stent is completely horizontal. And then you can see here the same maneuver, but with the flaring balloon. And this flaring balloon, again, is a 10x2. You need to use a short balloon, 2 centimeter. Otherwise, you will not be able to position it really horizontal. And if you don't get your balloon horizontal, then you cannot flare nicely the top and bottom part. You will only flare the bottom part. So to get a good seal, it is important to do that. Now this is a selective angio inside the celiac trunk, and you can see that both branches are nicely patent, the hepatic and splenic arteries here. Now I'm going to show you again the various steps of the procedures because there's been some concern about the metallic strut, cobalt chrome struts of the stent being inside of the bridging stent. In my practice, it is not an issue because I'll show you the way we do it. Oh, my video is not running. There we are. It was because of my pointer. So I just wanted to show you the various steps. Can you see the video? Yeah. So you see the sheath is now retrieved, and the B graft has been advanced. I am actually advancing the sheath before deflating the B graft balloon. So when I deflate it, the sheath just jumps into the target vessel. And you can see here the flaring balloon, and it's the same maneuver. You need 4 hands to do that. Once the balloon is inflated, I push on the shaft so I can nicely flare it. And I start pushing on my sheath before, you can see this is the 6 French 90 sheath. I start pushing on the sheath before deflating the balloon. So when I deflate the balloon, the sheath just nicely tracks inside the target vessel. So I never have an issue with a conflict, and this is the completion selective angio here in the left renal artery. What is this? This is the right renal artery. This is now working on the celiac trunk. It's the same maneuver again and again. The B graft here is protruding inside the aortic lumen. My partner is inflating the balloon. I'm going to start pushing on the 6th French sheath. There you are. And while deflating the balloon, I advance the sheath. So you see, they really track nicely all the time. The flaring with the 10/2 balloon of the celiac trunk fenestration. And you can see my position here. The two lateral markers of my fenestration are facing each other. So I'm sure that I'm in the right position to know how much of the stent is protruding inside the aortic lumen. This is a flow run showing a nice patent target vessel. And then the final one is the SMA. I think I'm going to run just to show you. Oops, I wanted to show you the cone beam CT. So this is the completion angio with the 4 branches, and then you see the cone beam CT with the rotation to check that all target vessels are nicely open, and we check on the cone beam CT everything. Because if needed, we can reline the stent or we can reballoon or whatsoever. Now, I think there's something interesting that has changed our practice is really to deal with those very complex target vessel and especially with the celiac trunk. You can see here with an arc ligament. What has really changed our practice, what has been a game changer, is the steerable sheath. This is really something that has helped us to deal with those complex cases. And you can see here, the steerable sheath is advanced in just the tip through the celiac trunk fenestration and gives you enough support to advance a wire and catheter and then to position it. And this is another example. See how difficult the celiac trunk is, but with the support of a 7 French or 8.5 French steerable sheath, you have enough support to get your wire catheter and then your bridging stent. And you can see here, the B graft has been nicely positioned inside this celiac trunk. And this is the post-op CT in this patient. Let me share with you our experience with the B graft peripheral in fenestrated endograft. This was my early experience, but I wanted to check my result. And so this was my first 101 B graft that had been implanted in 46 renal arteries and 55 visceral arteries. And we really looked for any type of issue, disconnection, type 3 endoleak, type 1C endoleak. We looked at everything in this 101 B graft. And when you look at those patients, one case was actually a very bad case because a patient presented bilateral renal issues, a dissection on one side and a kidney hematoma on one side. And so this patient had both renal occluded and was under dialysis after the procedure. But in the other patient, there was at 1 year, no more issue, no endoleak, no occlusion, no requirement for any type of secondary procedure. So those were the results at 1 year, and they were published in 2018 in the European Journal of Vascular. We just updated this series of patients, and we now have 3-year follow-up for those patients. So what is interesting to see is that after 3 years of follow-up, we only had 2 secondary procedures for a bridging stent. One was due to a undersizing of a bridging stent. The renal artery was not, we used a 6mm stent, and by ballooning it with a 7mm balloon, we obtained a seal. And another one was a patient who had a kink, and we reballooned it also. Now, if we look at occlusion of target vessel of those 101, I already talked about 2 early occlusion. It was a technical issue. The blame was on me. And then there was only one late occlusion in a patient. So if we look at those results, the 3-year patency of those 101 B graft was 97%. And the freedom from secondary procedure, including all secondary procedures, was 90.3%, but there was only 2 procedures performed for B graft. So regarding, if you look at this cohort of patients that were all, complex FEVAR, we're very happy with the results of the B graft peripheral in fenestrated endograft, and this is why it is now our #1 option. For the good results at 3 years for the 6 French compatibility, and we are soon going to publish a new study showing that it is very flexible. It adapts very well to the respiratory motion of the stents and to the movement and the anatomy of the visceral vessel. So in my mind, it's currently a perfect platform. And also the idea of having a short length in large diameters was also very useful. So I told you that I did not use the first generation of B graft peripheral, that I am very happy with the B graft peripheral for fenestrated endograft. And now, since 2017, I have started using the B graft plus, which is the new platform, which is equivalent to 2 B graft peripheral. You have 2 layers of cobalt chrome and 2 layers of EPTFE. And I was not convinced that the B graft peripheral was a good stent for branches. It was perfect for fenestration, but I'm very happy to use the B graft plus for my branch cases. And so the flexibility that you have with the B graft peripheral is less with the B graft plus, but you have a very stable platform that you can use in large sac. It's not going to move, and you will not have issues with sealing or with the EPTFE, any ballooning or any issues with the B graft plus. This is one of my first cases in 2017. This is a celiac chunk branch, and I used the B graft plus in this patient because there was a very severe arced ligament. And you can see here the sheath tracking back into the target vessel. And next, the angio showing a nice patency. And again, a cone beam CT. This was a case with 3 fenestrations with B graft peripheral and 1 branch with a B graft plus. And what you can see here is that the B graft peripheral is nicely open despite the arced ligaments. And you can see here a nice lumen of the B graft peripheral. Now, what has changed since we've started using this platform is that we are also doing our branch cases from a groin approach using also a cerebral sheath. Now, for those T-branch cases, we use a larger cerebral sheath than the one I was showing you before. This is a 16 French sheath. It's the Aptus sheath. It's the one that is usually used with the endo anchors. And so it is a very stable platform if you want to do those branches from below. So you see access to the branch. access to the celiac trunk, and then over that, the big graft plus has been implanted in the celiac trunk, everything from the groin. And this is really our number one technique to perform those branch cases. I can tell you for the last 2 years, I've done 95% of my T-branch from the groins exclusively, especially because the big graft plus tracks really nicely through the sheath when coming from the groin. This is a video that will show you a couple of steps in a T-branch that I did for an urgent case. You can see that we are doing everything under fusion guidance. Here, the 16 French sheath is advanced from the groin and then position to access the celiac trunk. You can see now my catheter advancing, and here I'm trying to get access and now getting access to the celiac trunk. And now the big graft plus is in position. We are now working the SMA, access to the sac, and then we are aiming at the SMA. And you can see the big graft plus in the SMA, and now we're working inside the right renal artery. For that renal artery, we decided to use, I think, a self-expandable bridging stent. And this is a completion angio with all 4 bridging stents that are nicely patent and with an excluded thoracoabdominal aneurysm. Now, another reason for working from the groin is that you reduce the stroke risk of your patient. And this has been nicely shown by my friend Eric Verhoeven when comparing chimney EVAR to fenestrated endograft. When you don't need to come from above, obviously you reduce the stroke risk. Now, another reason for working from the groin is that you can protect yourself against X-ray really nicely. Because usually when you're working from the top, from the axillary or the arm, you do not have this nice protection with shields above and below the patient. With this, when you're organized from the groin with this protection, you are completely free from any exposure to the X-ray. So in conclusion, there's a learning curve with using those bridging stents, a learning curve with using those new technologies, including, for example, the preloaded system and including the steerable sheath. In my practice, the big graft peripheral is really the #1 option for my fenestrated endograft. And the big graft plus is my #1 option when I'm using branched endograft, and you've seen that you can do those from the groin. Now, in some patients, when I do a fenestrated endograft and when the fenestration is far from the origin of the target vessel, or when the target vessel is diseased with the atheromatous stenosis, and if I want a more radial force, I'm also happy to use the big graft plus in some of those fenestrated endograft. So this is what I wanted to share with you today. And I hope you could see nicely the videos and all of that. And I would be very happy to answer any questions or any comments that you have. Thank you very much.
Thank you, Stéphan. Merci beaucoup. Thank you for your experience and your tips and tricks. Your information and your experience is very valuable for us. And I want to tell you that last year we in Colombia, we have done 227 T-branch at the date, which is a very good experience. But we are not yet doing, for most of the people, from below. And you tell us that in 95% of the cases you are doing from below.
Yeah.
Which are the cases where you can do it from below and you go to the arm?
So I'll answer to your very good question. But first, I would like to just give you another information. The cerebral sheath that I'm using from below is very expensive. And there are other ways of doing that, because I know that budget can be an issue when performing those expensive procedures. And my friend Thilo Kolbel has published an interesting report, I think, in the GEVT, where he shows that with a regular 12 French sheath that you push inside a 16 or 18 French sheath, but first you position a wire inside the sheath that you get on the other side that you loop. And then once the sheath is inside, you put some pressure on both sides of the wire. Then your 12 French sheath will position itself like a cerebral sheath. And then you can advance a longer 8 French sheath and access each target vessel. So that's a less expensive way of doing those procedures, because I think that can be an issue. Now, to answer, Juan, your question, I have been accessing from above when I'm using a system with preloaded wires, especially in dissections, when I want to make sure that my branches will not open in a, how do I call that? A communication tier between the true and the false lumen. I've been in a situation, and this is something I've published in the GEVT, I think recently, 1 or 2 months ago. I've been in a situation where the T branch opens, the target vessel is in the true lumen, but the branch is open in the false lumen because there's a big tear, and it's very difficult to find your way back. So in those patients, I use a preloaded system so that I am sure that I can advance a sheath to the true lumen from above. But those are the only ones. All the other cases, I do them from below.
And you use, I saw that you use an aptus system.
Yeah.
Yeah.
Yeah, it's the 16 French aptus sheath. I don't use the sheet.
Oh yes, of course, the sheet.
Yeah. Mm.
Good.
So sorry, just one point, because you're talking about the aptus. The aptus comes in 2 diameter of the tip. You know, the curve of the tip. It comes in 22 and 28. And if you want to have enough room to position the tip inside the branch, you need to use the short one, the 22. Because the 28, you don't have enough room inside the lumen of the T branch to nicely position. So that is important to use the small one.
Perfect. I have another question, Stéphan. With traditional cover stents, we routinely make reinforcements with bare metal stents in the previous generations and other stents to prevent modular disconnection or kinking. In which situation with the Big Graft Plus is this reinforcement needed?
So in visceral vessel, in the celiac trunk and the SMA, almost never with the branch coming downwards, the Big Graft Plus adapts really nicely. So I think I have never relied on SMA or celiac trunk when using the Big Graft Plus with branches. But with the renals, I think it is very important that you shoot a selective angio with the stiff wire that is not anymore inside the target vessel. So either you change the stiff wire for a floppy one, or you just move it back slightly. But I think that for the renals, it is important to check that you don't have a small kink. And if you have a kink, then you can rely with an item or stent. Having said that, I don't do it very often. I don't need to do it really often. And if I go back to my fenestrated experience, I think it is very, very important. I was talking about that during my talk. Also, to do the selective angio in the SMA with a floppy wire, not with a stiff wire, to check that there's no kink between your bridging stent and the SMA. Now that I'm using the B graft with a 27 millimeter length, the number of bridging stent inside the SMA that I reline is less than 10%. Before, it was 80%. So really, this has really changed using the B graft.
Good. Another question from the audience is, in the situation, we are talking about fenestrations in renals. So the B graft plus doesn't have a 22 millimeters, only 28. That's correct. So you are always using the 28 for renals, or do you think that you're still using sometimes 22 millimeters long for the renals, or you are only using B graft plus?
No. For the fenestrations in the renal,
yeah,
I use the B graft peripheral. I don't use the B graft plus, except in a very limited number of cases where the fenestration is very far from the origin of the target vessel.
Any reason?
I really want something very, very strong to bridge the gap. But this is something that I do maybe less than once a year. But all my renals and with the fenestrations, all the other ones, 98%, are a big graft peripheral. So, and I use most of the time the 22 millimeter length big graft peripheral, not the 28. Having said that, in some cases, I need to use the 28 because of the anatomy, because the origin of the target vessel is large. So I'm happy to have this option, but my number one design is a 6, 5, 6 or 7, 22 or 23 if it's 7 for the renals.
Perfect. I don't know if there's any question. Hay algunas otras preguntas. Estoy viendo el chat y no veo algunas preguntas. ¿Alguien tiene otras preguntas para hacer a Stéphan? ¿O algún comentario? Las personas que están conectados, Fernando, Jorge Hernando, Héctor, ¿algunos comentarios?
Juan, yo tendría una pregunta. En los casos que la guía Rosen no da suficiente soporte, ¿utiliza alguna otra guía?
Yeah.
Por decir, un Amplatz, un Lunderquist o algún truco especial.
Stéphan, Fernando is asking about the wires. Usually we use, as you, Rosen, but sometimes we have some trouble, sometimes in renal, sometimes in SMAs. Which is your alternative wire to the Rosen wire when you have some cases where the stent is not going well?
So it's a very good question because this is something that happens once in a while. I have to tell you that the Rosen is really my favorite wire. Sometime in the SMA, you need a bit more support, and then I would use the short tip Amplatz. I think it's a good option, but it's a dangerous option. I think that you have to be very careful when you push an Amplatz in the SMA that it doesn't move backward and forward, because it's the best way to do a dissection of the SMA, or to get into a small branch and rupture it. So every stupid, I've done it. So I can tell you that I now always check that I am in the main trunk of the SMA prior to advancing my wire. And if I have especially a stiff Amplatz wire inside the SMA, I am really always focused on the tip of my wire to make sure that it doesn't go back and forth. I never use along the quest into the renals or OTD-SMA. I think that, again, coming back to the cerebral sheath, for those difficult cases, we don't need anymore to use very stiff wires. And so sometimes when I really struggle, I don't have enough support, I switch, I use the cerebral sheath, and then everything tracks well with the Rosen. And I also use the Rosen when I do my from below. Again, I think it's quite a safe wire because usually with the atraumatic tip, you don't do anything dangerous or stupid.
Perfect. Let me ask you again, because it's very important for us. You say that the non-chip deflectable catheter, you do it with the 12 French standard catheter. And can you repeat this trick, please? Okay.
And if you want, I will send you the reference of the case report from the team from Hamburg. So what they do is first the 018 wire into a 12 French sheath and get the wire out. So you have a loop, and then you push the 12 French sheath into a larger sheath, like a 16 French sheath. Once the sheath is inside the aorta above the branches, you pull on both ends of the 018 wires. So the sheath will end, and then you advance another sheath inside the lumen of the 12 French sheath, an 8 French sheath, that will now come, and do the curve and come down. And using that sheath, you will selectively go to each branch and then advance your bridging stents.
That means 8 French flexor and 12 French flexor.
Yeah, a 12 French 45, which sometimes can be a bit short. The patient is tall, but it is a 8, and then 8 French. You can use a 55 or a longer one, or if you need.
Good, very interesting. We're going to try that.
It's Haulon. Because you had a question?
Yeah. Hector?
Thanks for a magnificent presentation. The question is, if you have an occlusion or thrombosis, renal occlusion or renal thrombosis in postoperative time, what do you do? What's the specific steps for management this patient?
So if you have an occluded target vessel after the procedure?
Yeah.
Okay. So I'm sorry, I'm going to tell you again that we use cerebral sheath, and then we use a, how do you call that? A guiding catheter, and we thromboaspirate with a guiding catheter. So we try to get a clot away. So we put the sheath, the guiding sheath at the original target vessel. Then we push the guiding catheter inside, and with a syringe, we try and get the clot back. Sometimes we do some local lysis, and most of the time there's a good reason for having an occlusion. So if there's a kink in the target vessel, we add a self-expandable stent. If we need, we use a longer bridging stent, and so depending on what we find. I don't have a huge experience with the occluded target vessel, thanks God, but in a couple of cases, this is what we have done, and get a maximum clot out, trying to find out why the patient occluded, and then treat that. I think there's a nice paper. I was part of a group of many centers that published on occlusion of renal fenestration and branches. And there was something very interesting, is that when I was a resident, I learned that you only have 6 hours to restore flow to the kidney. And what the group showed is that you can actually try to restore flow even later, 24, 48, 3 days later. It is still worth trying to reopen and store flow to a kidney, most patients will recover. So this is something that was interesting in this multicentric experience.
Stéphan, in the same way of question, sometimes you have T-branch that you have as a standard device that not custom made for most of the cases in Colombia. Sometimes you know from the beginning that usually the celiac trunk is occluded. Which is your preferred alternative? You prefer to put an Amplatz device there, or as we do sometimes, we open the device and we suture the device and reopen. What do you do?
So I don't open the device, and I'm not allowed to do that. I do think that I'm not allowed to, but this is a recorded session. Usually what I do, especially, you know, in those acute cases when you want to go quickly, what I do is I put an implanter, but not directly into the branch. If you do that, I don't trust that you have a good seal, and it might move. So usually I first position a graft inside the branch. I use a 37 or 57 B graft. And once I have positioned the B graft, I put 1 or 2 implanters inside. I think it's the best way. It's not cost effective, but I think it's the best way to get a perfect seal. So if it's a visceral branch, I would use a 957 and then put inside 2 12-French implanters.
Yes, because it's a problem that because the implanter alone can move with the systole.
Exactly. If you put only an implanter directly into the branch, it will not stay. That's why I first put the B graft, peripheral, and then I put the implanter inside, and it never moves.
It's a good trick. You know, it's cheaper for us to open the device and suture the branch, and we have done 4 or 5 times, and it's good. Because we are concerned about the moving or the migration of the implanter during the time.
I fully agree with you, Juan. I think that it doesn't work to position only an implanter through the branch. I think it's not safe. And I think that even if you don't see a leak, you have endotension, and I don't think that you nicely exclude the sac.
Perfect. Jorge, estamos en el tiempo y Fernando, ¿algunos comentarios finales o cierre de sesión?
Y, pues realmente una conferencia espectacular. Really thank you, Dr. Haulon. Very nice conference. We learned so much. Yo tomé algunos apuntes sobre algunas cosas para decir, pero creo que me gastaré otra hora hablando de todas las cosas que aprendimos. Definitivamente es muy interesante el truco de dar la vuelta por encima sobre el top cap para sostener el introductor y poder canalizar y avanzar el balón coda. Algo muy interesante es también, y pues resaltando lo dicho, es el uso en el T-Ranch, utilizando el T-Ranch y canulando todo desde abajo con el dispositivo deflectable. Estamos de acuerdo, el dispositivo de Aptus es bastante costoso, muy interesante, al igual que la liberación simultánea de los dos introductores 6 French y los 2 balones en los 4 vasos para poder estabilizar el dispositivo antes de soltarlo. Valorar mucho también la flexibilidad y el perfil del B-Graph, porque es muy probable que ningún otro dispositivo de Stent recubierto pueda llegar a generar esa flexibilidad y esa facilidad para avanzar y entrar en anatomías muy curvas. Realmente aprendimos mucho, Dr. Haulon, really thanks. And muchas gracias también a Twins, a Jorge Hoyos, a Héctor Jiménez y a todo el equipo de soporte de esta transmisión, que ha sido muy interesante. Para nosotros acá en Colombia es un horario bastante complejo, pero estoy seguro que las retransmisiones y las vistas que vamos a tener en la página y en nuestros canales de YouTube y de Facebook seguramente van a desbordarse. Dr. Haulon, really thanks, and Jorge dejó para el cierre.
A todos ustedes, muchísimas gracias. Nuevamente, Twins and Martin, perfecto. Todo este proceso, el apoyo, almuerzo de trabajo, es lo que estamos haciendo, un almuerzo de trabajo, estaba pensado. Doctor Varela, doctor Fernando Mejía, muchísimas gracias. A Héctor Jiménez, nuestro piloto de estos webinars, impecable como siempre, al soporte técnico que nos ha dado Estefanía, excelente. Monsieur le professeur Haulon, encore une fois, une présentation fantastique. En mon nom de même Société Colombienne de Chirurgie Vascular, merci beaucoup. Muchas gracias a todos, un abrazo muy grande y nos estamos viendo. Seguimos conectados ahora en la tarde con la sesión de las 3 a 5, la parte venosa, y tenemos la parte arterial antes también, en donde Fernando y yo estaremos manejando en Endolat y los esperamos con los brazos abiertos. Un abrazo muy grande a todos y una feliz tarde.
Merci, Stéphan. Au revoir.
Stéphan, muchas
Merci
gracias.
beaucoup.
Merci beaucoup.
Otra cosa última, antes de
última
cerrar.
cosa.
Stay safe, everyone. Bye-bye.
Oui.
Una última cosa.
On Saturday, you are going to be again with the Costa Rican Society. Stéphan va a hablar otra vez el sábado sobre estos mismos temas. C'est ça, Stéphan? Tu vas parler samedi à la Société de Costa Rica, c'est ça?
Ouais.
Perfecto.
Entonces, el próximo sábado, 9 de la mañana, Stéphan otra vez va a estar en vivo y estamos invitados cordialmente también para eso. Jorge, muchas gracias a los Jorges y fue, creo que, una magnífica experiencia y una magnífica sesión. Muchísimas gracias.
Yo para cerrar, rapidito, para agradecer a Twins and Martin y a Stéphan, por supuesto, por todo, para que todos sepan que ambos dispositivos ya están disponibles en Colombia, y siendo Colombia el primer país latinoamericano que va a tener el Big Graph Plus a disposición. Eso es todo. Merci beaucoup, Stéphan. Au revoir.
Au revoir. Merci.